from Malaysia. Assalamualaikum and a very good morning or good evening or perhaps good afternoon. So since all of you have been coming from all around the world, so I would like to wish you a very good day to all the speakers, panelists and delegates from Malaysia, Singapore, Taiwan, Indonesia, Arab and Vietnam. And I would like to wish thank you to each and every one of you for being here with us today. So it's already 5:05 and we are very pleased to be able to welcome those of you who have been with us for a long time, as well as those who are new to the Laryngology Network or group. Yeah. So today marks our 15th annual Laryngology and Phonosurgery workshop, and we are proud to be able to host it on a virtual platform in the form of webinar with all of you. Before we get started, I would like to express my sincere appreciation to all of you who have generously helped to make this event come together, including our industrial partner. So in this webinar, Pentax Medical was a proud sponsor to this workshop today. So our workshop today is entitled Benign Causes of Dysphonia. Now I am ready to launch the poll for today's webinar. We've got a poll for all of you to answer. So I'm relaunching the poll now. So you can answer the poll and we will share the results of the poll at the end of the webinar today. And I hope we can have participation from all of the participants to answer the poll questions. They are very simple questions for you to answer. So all the delegates are welcome to key in the response. And after this, I am going to show a short video from our industrial partner, which is Pentax Medical, on the latest V-video technology. There you go. Thank you very much for listening to the video, and let us welcome Professor Dr. Marina Baki, the Course Director of Laryngology Webinar Series 2021, to deliver her welcome address and opening speech for today's webinar. The floor is yours, Prof. Marina.
Thank you, Professor Mawada. Is it possible for me to share the screen?
Yes.
Okay, thank you so much. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good day to everyone. This welcome address will be a short one, inshallah. All right, so I would like to welcome everyone, all participants from Malaysia as well as abroad. Thank you for participating in this laryngology webinar. So as Prof Mawada has mentioned, this is actually the 15th UKMMC, UKM Medical Center Phonosurgery Laryngeal Phonosurgery course. But because of the COVID pandemic, we have to convert it to Laryngology webinar series. However, I think for this one, the lectures are longer and will be more in detail because we would have 4 sessions, and each session we will be discussing different kind of themes. So, and I would like to welcome and thank all the distinguished faculty members. I would say their name and from where they're from, just briefly, because the moderator would introduce them further and in detail before each talk. So first is Professor Dr. Tuan Zheng Fang from Professor Dr. Tuan Zheng Fang from Laryngology Memorial Taiwan Hospital. Assistant Professor Dr. Bias Prasad from MWH Medical Specialist Center, Singapore. Assistant Professor Dr. Thomas Carroll from Brigham and Women's Hospital, Harvard Medical School of the United States of America. Dr. David Lau, Gleneagles Medical Center from Singapore. Dr. Fauzia Fardiza from Cipto Mangunkusumo, Universitas Indonesia. Professor Dr. Abdullah Sani from Avicenna Women's Children's Specialist Hospital, and he is still our visiting professor of UKM Medical Center. Professor Abdullah Sani is the founder of Laryngeal and Phonosurgery course. He is my teacher and teacher to many people, and I call him Master Yoda. And Dr. Naristiman Satya Murthy from Hospital Kuala Lumpur, who is a cardiothoracic surgeon, will be sharing with us in other session. Professor Dr. Muhammad Zulkifli Abu Bakar from University Malaya Medical Center, Kuala Lumpur. Professor Dr. Masani Mansur from University Technology Mara, Sungai Buloh. And Associate Professor Dr. Mawada Azman, who is also the course coordinator of the Laryngology webinar. She's the backbone of this webinar. Dr. Nik Fariza Husna Nik Hassan from University Science Malaysia Medical Center, Kelantan. And Madam Nosharina Muhammad Zawawi, who is the speech language pathologist awaiting for her PhD to complete. So, and as I have mentioned, we are going to have 4 sessions, and I hope everyone would put in the diary quickly the dates and the time, because it's slightly different from one to another one. And for today, the theme is on benign causes of dysphonia. Professor Mawada will brief, and this is specially sponsored by Pentex Medical. So I just showing you our previous year of laryngeal and phonosurgery workshop, which we cannot do it today because of COVID pandemic, but we would be able probably do just cadaveric dissection whenever the COVID pandemic is over and when many people will be vaccinated in Malaysia. And this is the picture. And before I end the welcome address, thank you for all the sponsors. Pentex Medical, Sostos, Umi Surgical, ISMED, and SIS Healthcare. And today, the main sponsor is Pentex Medical. I think with that, thank you so much. I give the floor back to Professor Mawada.
Thank you, Professor Marina. So as we have briefed in the pamphlets of the webinar today, we'll be starting off the webinar with 3 talks by our 3 distinguished speakers. And then we are going to have case discussions as well as question and answer sessions with the participants. So before we start our talks, I would like to make some housekeeping announcements. So I would like to remind all the attendees to mute your microphones during the lectures to reduce disturbance. And we will be showing videos of patients in which some of the videos you'll be able to see the patient's face, and these may be identifiable. So we would like to make short notes for all the participants not to record any portion of this webinar. Should you need any of the recordings of the webinar, you may write an email to us, and we are more than happy to provide it to you screen recordings of the webinar in which the videos of the patients are edited out. So if the participants have any questions or comments to make, please drop them at the question and answer box below. It is located at the lower portion of the Zoom button there. please do not put them at the chat box. I won't be able to see the questions. Just put them out at the question and answer box. So the panelists will be able to answer all your questions either by typing them out in the chat box, or specific questions which require further elaboration will be answered live by all the by all the speakers. So we are more than happy to address all your questions. So don't be shy, put on all of them and make full use of the webinar today. We have a good 3 hours to discuss on all the topics pertaining to the webinar theme for today, which is benign causes of dysphonia. Yeah. So do tune in until the end, as we will share the MMA CPD QR code at the very end of the webinar, which inshallah I think will be around 8 p.m. and we'll be able to Salat Maghrib at that point of time. So without further ado, I would like to start off the first topic for today. So I would like to introduce our first speaker, which is Dr. David Lau from Singapore. Dr. Lau is an ENT surgeon in private practice, and he has over 25 years experience in the specialty. He has a subspecialty interest in laryngeal, voice, and swallowing disorders, and his research areas have included voice outcomes after vocal fold medialization, development of a novel single-step method for outpatient tracheoesophageal puncture, and Raman's spectroscopy for optical diagnosis, and breathing techniques in the treatment of laryngeal muscle misuse disorders, including chronic cough. He has directed a number of courses on laryngeal laser surgery, dysphagia, and transnasal esophagoscopy, and he was the organizing president of the Asia Pacific Laryngology Association Conference in Singapore, which was held recently in 2019 before the pandemic outbreak. So despite a busy private practice, Dr. David Lau has continued to be active academically, teaching regularly both locally and regionally, and maintains visiting consultancy at the National University and Singapore General Hospital. So Dr. David Lau will be talking on characterizing benign vocal fold lesions, and the microphone is all yours, Dr. David.
Thank you very much, Prof. Madia. I'm going to share my screen now. Okay, are we able to see everything?
Yep.
Okay, so I will spend the next 20 minutes, I will try to finish on time, talking about characterizing benign laryngeal lesions. Okay, now. Okay, so I have a few, I'm posing a few questions and I will try to give answers to some of these questions. So the first thing is when we see a lesion on the larynx or the vocal folds is, do we actually need to operate on this lesion? And I think that is one of the questions that was posed in the poll. We determine if surgery is needed. And the first question is, do we actually need it for a diagnosis? Video stroboscopy plays an important role. And this allows us to have a magnified view of the larynx. It allows us also a slow motion assessment of the vocal fold movement. So there's a few examples here. This is one example, and you can see that this is a pair of vocal nodules. Here we have a very smooth looking polyp, and here we have what is an intracaudal cyst. And you can see in these three lesions that surgery may not be necessary for a diagnosis, and you may be able to make the diagnosis quite clearly with the laryngoscopy in the outpatients alone. What about this lesion here? So there's a leukoplaque here of the vocal fold, and this lesion where there is also a polyp, but it looks a little bit more different from the one in the top middle. And in these situations, a biopsy may be helpful. What about this lesion here? So this is not a polyp. This is in fact contact granuloma. And in this situation, these patients are typically treated with non-surgical means as a first line. However, not all posterior vocal fold lesions are contact granulomas. And this particular lesion here, sorry, this particular lesion here, we biopsied because it did not respond to proton pump inhibitors and conventional medical treatment, and it turned out to be a smooth muscle tumor. This particular lesion here also looks like a contact granuloma, and this one actually ended up being a carcinoma. So in other words, we shouldn't brush off a lesion necessarily simply because it looks benign. The second question when deciding about surgery is whether or not surgery will improve the patient. And there are a few other questions that we then have to ask. The first that I typically ask is the lesion actually affecting the voice? And we can ask the patient this. The stroboscopy can be useful. It may show that the lesion is either preventing vibration of the vocal folds or preventing proper closure of the vocal folds. The next question then is, how disabling is the lesion to the patient? Is the patient simply slightly hoarse, or are they disabled and unable to function in the normal fashion? Have the underlying causes of the lesion being treated? And is there a likelihood of making things worse with surgery rather than better? And are there any alternatives to surgery? So these are all the questions that we need to ask. So let's have a look at an example of this. So this is an example of a patient who has what looks like either a polyp on the right vocal fold and a thickening on the left side, or possibly vocal nodules. And in these patients, typically we want to treat the underlying causes. And there are 4 key sets of underlying causes. These are the patient's lifestyle, the presence of reflux, their vocal technique, as well as some various emotional factors. So someone who uses their voice very forcefully, for example, may be more likely to run into problems such as this. So it is important to treat the underlying cause to improve the voice or prevent recurrence if surgery is considered necessary. And in this particular patient, the patient was treated with 3 months of proton pump inhibitors and strict voice rest, and you can see that the lesion actually resolved completely. An alternative to surgery, which ought to be considered, is steroid injections. And this is a report of a series of over 80 cases of small benign lesions, so such as nodules, polyps, and Reinke's edema, where steroid was injected through the cricothyroid space into the vocal fold, and they observed complete remission in just under half of the patients. There was, however, a proportion of patients in which there was no response, or in which there was a recurrence. So the next question then is, what modality of surgery should be used? Should we use cold instruments, or should we use the laser to carry out the surgery? And the decision might be made by how bulky the lesion is and how likely it is to bleed. So one example is respiratory papillomas. Now you can see from this picture here, if we try to excise these with cold instruments, bleeding is very likely, and an accurate surgery may be quite difficult to perform. So in this situation, the laser was used. Another example where the laser is very helpful is patients with contact granuloma. So this is a patient with a left-sided contact granuloma. These can be very vascular, and if we try to remove them manually with cold instruments, it can be very difficult to get an accurate removal. When we use the laser, you can see in the picture on the right that the base is nicely defined and cleanly removed. The post-op care for these patients becomes very important because there is a high recurrence rate. But if we are very careful with voice rest, managing reflux, and sometimes using Botox to temporarily paralyze the vocal fold, then these patients can heal up very nicely. Another question in dealing with benign lesions is, will there be challenges with exposure when we are performing the surgery? And what we want to look at is, we want to look at the patient's mouth, we want to look at their chin, and we want to look at their neck. If they have a very crowded oropharynx, they have a small chin, and they have a thick neck, then we have to be prepared for a difficult surgical access, particularly to the anterior commissure. We need to work with our anesthetist, bearing in mind that the space in the larynx is narrow, we are sharing the airway, and we should use small diameter endotracheal tubes or jet ventilation. We need to choose an appropriate laryngoscope. I tend to like using the Dido pilling laryngoscopes. So we have one that is suitable for laser surgery, one that can be used with cold instruments, which doesn't have an extra suction port. And we have a special small bore scope for anterior commissure lesions. The Lindhole laryngoscope is also quite popular and gives a very nice wide access. I find personally in Asian patients that it can be very difficult to get a nice, easy access to the vocal folds. The other problem with this is that the blade sits in the vallecula, and if you put too much tension on the laryngoscope, it can result in injury to the hypoglossal nerve as well as to the chorda tympani. We have to position the patient carefully, and we use the so-called sniffing the morning air position with the neck flexed and the atlanto-occipital joint extended, as you see in the picture here. And we may want to apply some external compression in order to view the anterior commissure more clearly. Care has to be taken to protect the tissues, both the teeth as well as the soft tissues of the lips and the tongue and the temporomandibular joint. We want to use high-powered magnification with a binocular microscope most of the time. We want to use a long focal length. So we use a 400 millimeter focal length. And this is in order that there is enough space between the laryngoscope and the microscope that we can place the long instruments through that space. And we want to use as high-powered magnification as we can in order to get a very clear view of the lesion and surrounding tissue. Next question is, are there any special anatomic considerations when we are performing surgery? And the first one of these is that we should always try to preserve normal mucosa and avoid injury to the vocal ligament. It is very important to have a good understanding of the layered structure of the vocal fold, which consists of the epithelium, the underlying superficial lamina propria, underlying which is the vocal ligament, and then the muscle tissues. If we damage the deep layers, then we are likely to create more scarring, and that's going to disrupt vibration and could make the voice worse rather than better. We want to maintain the integrity of the anterior commissure. Now, if you look at this lesion on the left side here, this is a patient with respiratory papillomatosis on both sides and extending across the anterior commissure. Now, if we were to try and remove all of this in one go, we may end up with bilateral raw surfaces and scarring and web formation. So in this particular patient, I performed the surgery in stages. So one side was performed, a few weeks was given to allow this to heal up, and then the opposite side was operated on. And this was the final result. If we are not judicious with our protection of the anterior commissure, we can end up with anterior web formation, and this can be a very serious problem for the patient and can be very difficult to correct. Next question. What surgical approach should we use and for which lesion? So we'll have a look at a couple of examples here. So the first lesion is a vocal polyp. You can see in the little video on the left side, vocal polyp on the left vocal fold. And it seems to be impairing the vibration of the vocal fold, and the patient complains of hoarseness. This particular patient was a teacher. And if you look at the section here, essentially what we do is we want to remove the polyp without extending the incision into the deep layers. In other words, we keep the incision within the superficial lamina propria and the epithelium. This is an example of a polyp here, and you can see that there's a fairly significant blood vessel feeding the polyp. And after excision, it should look something like that. And you can see, so this is immediately after excision intraoperatively, you can see that only a small amount of mucosa has been removed and the feeding vessel has been cauterized. This is another polyp of the mid-vocal fold, and after excision, immediately after excision, you can see There's a small amount of missing epithelium, but otherwise the vocal fold looks fairly normal. One technique that is important in order to preserve the deep layers is to avoid excessive traction on the lesion or polyp when we are doing the excision. So if you look at the top picture, if we don't put too much traction, then we end up with a smooth mucosa. If we put an excessive traction and we excise it, we could end up with a divot or a dip in the vocal fold. Another technique is to use subepithelial infiltration. And what this does is it distends the superficial lamina propria, it lifts the epithelium off the vocal ligament, and it helps with incision and dissection. And it reduces the risk of injury to the vocal ligament. Typically, we'll inject something like normal saline, and we only need a small amount, less than half a mil. The second type of lesion is vocal cyst. And if you look at the left-hand picture here, you can see that there's a vocal cyst, and it is inside the vocal fold. So unlike a polyp, this is actually intracaudal, and the approach therefore is different. And the approach requires a flap elevation. So we make an incision over the polyp, away from the free edge of the vocal fold, and we dissect out the cyst. And I believe Professor Marina will be talking more about this later. And once that has been done, we then lay the flap back and allow it to heal. This is just a short video clip of microsurgery for a laryngeal cyst. And what we're doing here is we're just examining the opposite chord. We then look at the side with the cyst using high-powered magnification, so as high as we can manage. You see there's a little bit of thickening over the vocal fold, and we make an incision slightly away from the lateral, from the free edge of the vocal fold. And then we gently retract the mucosa, and you can see that the cyst is lying underneath. We free up the attachments. That. In this case, we're able to actually grasp the whole cyst and dissect it out. Larger cysts, more dissection may be required. We then might want to trim off any excess tissue, any loose tissue. And we then decongest the tissue with adrenaline-soaked patties. And you can see that the mucosa is now nicely intact, and the incision will close very nicely. Now, we have explored the possibility or the options of different ways of closing incisions. So sometimes we make a very long incision along the whole length of the vocal fold, and we may need to either put a stitch in this. We have explored the possibility of using micro clips, but this is experimental. I'll just show you the video.
That's two.
And we use the cup forceps to make a sort of C shape, make the clip into a C shape, a little bit like a stapler. And this was published in the Laryngoscope some years back. Okay, the next question then is, what do we do post-operatively in order that our surgery to the benign lesion heals well? Good post-operative care begins pre-operatively. We need to discuss the procedure. We need to discuss the risks, the post-op care, alternatives, as well as the expectations for the patient. We need to make sure that the patient actually understands all of these aspects in order to get the best possible results. I typically ask my patients to undergo complete voice rest for up to 2 weeks after performing surgery for a vocal lesion. And this includes no whispering, no talking, no throat clearing, and no coughing. After that, they can gradually increase their voice use over the next 4 weeks, usually with the help of a speech and language pathologist. I will sometimes prescribe cough suppressants, mucolytics, and reflux treatment. And obviously, the patient should be advised not to smoke if they are smoking. And I will typically get them to discontinue this before we carry out the surgery. We have to remember that persistent hoarseness can occur even after surgery to the vocal fold. And this can occur for several reasons. We may be carrying out inadequate surgery, so there may be residual pathology. We may not have treated the underlying causes. Remember, that's lifestyle, emotion, reflux, as well as technique. And this can result in recurrent pathology even after doing a perfect surgery. We may be over-aggressive, which in our surgery, which can cause damage and scarring, or there may simply be poor post-op care, which also results in damage and scarring. So each of these has to be taken into account. And just some final words now, just on vocal polyps, and this might give you some clues as to the some of the answers to the or the answer to the poll. The first one is that not all polyps are suspicious. The second is that not all polyps cause voice problems. The third is that polyps can improve even without surgery. The fourth, which is a continuation of the third, is that polyps do deserve consideration of conservative treatment. And the final thing is that removing polyps can actually increase your voice problems if the surgery is not carried out carefully. And with that, I would like to thank you very much.
Thank you, Dr. David. It was a wonderful talk. You had very succinct points and it was very easy to follow with very practical highlights on the clinical findings as well as how to manage the patient. Thank you, Dr. Lau. So our next speaker is Dr. Abdullah Sani. Dr. Abdullah Sani is a professor and senior consultant of otorhinolaryngology and head and neck surgery, teacher to most of us here. And he obtained FRCS Edinburgh in the year 1990 and Masters of Surgery in otorhinolaryngology and head and neck surgery in 1991. With 30 years experience in otorhinolaryngology and head and neck surgery, he has contributed to various clinical researches, and his area of interest are snoring, sleep apnea, laryngeal and voice disorders, as well as laser surgery for laryngeal lesions. So he has spoken in numerous conferences and has about 34 local and international publications. So Professor Abdullah Sani will be talking on functional voice disorders, and the floor is all yours, Prof.
Thank you very much. My voice okay? Mawada? Okay, thank you. So I've been given the task of speaking on functional voice disorders. What are functional voice disorders? Now, these are voice disorders that occur with no obvious anatomical or neurological abnormalities of the vocal cords. Typically, the following are included in this group: muscle tension dysphonias, bubophonia, conversion disorders, paradoxical vocal cord movement, presbyphonia, spasmodic dysphonia, and essential voice tremors. We will go through these topics one by one. Why are these important? These are important because there is a need for the disease to be recognized, diagnosed, and properly treated. We need the existence of speech therapists, and we need to know which one in which disease process we need our procedure, our Botox, and in which disease process the speech therapist plays a primary role. Their greatest strength, of course, is the time they spend with the patients, and they have so much time with the patients. I wish I had more time. Now, coming to the first topic, muscle tension dysphonia, MTD. This is characterized by hyperadduction of the false cords when the patient speaks. There is hoarseness, which is worse on prolonged use, and typically worse in the afternoon rather than in the morning. There is pain, and it's probably the only voice condition when there is pain on speaking. And this pain is caused by strained muscles in the neck. Obviously, they are relieved by voice rest. And there is usually an underlying disease pathology that brings about muscle tension dysphonia. Now, the treatment is you must address the underlying disease, and then we refer the case to speech therapy. In the treatment of reflux, do not waste time on antacid and so on. You just go straight to proton pump inhibitors. Speech therapy will only have the desired effect if the patient is compliant and can understand and follow the instructions of the speech therapist. Now, the best treatment is voice rest and a change in the occupation to one that demands lighter vocal duties. Now, it's easier said than done, but this is what is needed. Many of my patients with MTD are teachers, and you can't tell them to stop teaching and get into another profession. They get better when they pension and when they stop teaching. Okay, oromanual dystonia is divided into the jaw opening and then jaw closing variety. Now, this is a teacher, this lady is a teacher from Pahang, and as she speaks, she closes her jaws. She closes her jaws, and you will see this.
Saya masih kecil, saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak.
Kuat?
Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak.
Now this condition is totally involuntary, and she cannot help herself. She cannot help closing her mouth when she speaks. Now the treatment is by Botox. Well, you need to inject we need to inject the masseter muscles and the pterygoids. Now the masseter is easy enough, but when it comes to pterygoids, it's very tricky to inject the pterygoids. I've seen it being done when I was in the US. Now, this patient was offered Botox injection, but she refused, and therefore she just went back to Pahang and went on with her jaw. Now, the opposite of jaw opening is the opposite of jaw closing is jaw opening dystonia. Now, when the patient speaks,
Masih kecil.
tengok atas.
Saya tinggal di kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal bersama ayah dan mak.
Kuat lagi.
Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke sana.
So there is an involuntary inability to close your jaws to pronounce the words properly. Now, this gentleman has found a way to overcome this. Okay, and what he does is he bites on a toothpick.
Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal bersama ayah.
If you notice, there is a toothpick here, and according to him, his voice is better by biting.
Ayah dan mak. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke sana, ayah, mak datang menziarahi kami di kampung. Saya gembira apabila mereka datang kerana saya boleh bermain.
Okey, buka tu. Cuba kan? Lagi sekali.
Okay, right. I do not recommend this to other patients because you might accidentally aspirate the toothpick and you end up with a foreign body in the lungs. Okay, I do not. But you know. But anyway, there's nothing to Botox. Okay, there's nothing to Botox. Right. This is another one. Another patient with a jaw opening.
Cuba kira 1 sampai 10.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
Right, there's obviously a failure of the patient to control the mouth, and this jaw opening dystonia. Next, now this big group, more important group, is the spasmodic dysphonias. Now this is very important because these are commoner than the previous oromandibular dystonias. Now 90% of them are adductors, so much so that you think that adductors are the only patients, the only patients with spasmodic have adductor spasmodic dysphonia. But there is a small group, 10% abductor spasmodic dysphonia. There is choking, a choking informal speech, and it is due to excessive and abnormal adduction of the vocal cords. But singing and laughing is normal. This is very peculiar to this spasmodic dysphonia. We really ought to investigate these patients. Especially we need to do an MRI of the brain, make sure and the thyroid function test, just to make sure that, that there is no organic lesion. The abnormality lies in the neurotransmitters in the basal ganglia. The treatment is primarily by injection of Botox to the adductor muscles, in particular the LCA, the lateral cricoarytenoid, with or without EMG control. Presently, we do injections by direct visualization without EMG, and in some places, of course, they do type 2 thyroplasty for this. Thyroarytenoid myoneurectomy is a surgical option, but we have tried it on one patient, and unfortunately, we did not get good results. And it's much easier to inject Botox than to do this operation. This patient, you listen to the voice.
And the sunlight strikes raindrops in the air, act like a prism and form a rainbow.
So there's difficulty in speech. Now the next one also has the same.
They act like a prism and form a rainbow. A rainbow is a division of white light into many big.
Tak tahu ya. Kalau ketawa tengok ketawa. Ha ha ha. Hah? Macam mana? Ketawa. Cuba.
Ketawa is okay. So this is him after injection.
When the sunlight strikes raindrop in the air, they act like a prism and form a rainbow.
Again, you notice the characteristic hoarseness, but the smoothness of the smoothness in flow of the speech is much improved. Now, this is the way we used to do this with EMG control. We use the EMG. Say E. And when you hit the muscle, you hit the muscles, you know this is the place we inject. But now we have abandoned that, and we have gone injecting the Botox by direct visualization of the needle. And as you can see, the needle is coming out anteriorly, and where the needle is, we find our way just lateral to the vocal cords. And when we reach this place, when the needle is in, we inject the Botox. And then when we remove the needle, there'll be some blood coming out. We know that we hit the right place. There we go. And out comes the needle. And this technique has saved us from going to the EMG room, or we are at the mercy of the people running the EMG. With this, we can do it in our clinic easily. And the results are pretty good. Then the rarer form is, of course, the abductor spasmodic dysphonia, and the patient speaks. There is breathiness in the voice.
Okay, but you have to be okay. Okay, tell me, where do you stay again?
Okay, I stay in Tawantun.
And how long have you had this voice problem?
Since early 2002.
And tell me, what makes it worse?
When I try to start to explain to people or try to talk at length, it starts to disappear.
Okay.
Now, I was trying to crack a joke.
Disappointing, frustrating. I've lost my self-confidence, my self-esteem. Yeah.
Okay, please count 1 to 10 for me, please.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
What about coming to Portugal with me?
Oh, I'd love to come to Portugal with you. That would be absolutely fantastic. Dr. Lisbon.
Okay, that is her normal voice. I was trying to crack a joke, and she became happy, and normal voice came out. This is so the change from abnormal voice to normal voice when you laugh and when you sing is typical for spasmodic dysphonia. Now, voice tremors, the essential tremors, the benign essential tremors of the voice. This is not the same as spasmodic dysphonia. Okay, they involve tremors of the supraglottis, the base of tongue, and in the severe cases, the neck muscles and other parts of the body. Maybe part of other neurological diseases. They are more resistant to Botox and may need medications such as propranolol. Now, this patient's voice not too bad.
Rainbow passage, when the sunlight strikes raindrops.
Not too bad, but when she starts to say E, you can hear the tremors.
7, 8, 9, 10.
Okay, say E for me.
E,
Longer, please.
E,
Longer, please.
E.
Very. So the treatment is of course a Botox. The Botox we can get rid of the tremors. In this patient, he refused all treatment. Now there are other causes of abnormal voice, and in this patient, she had a stroke, a cerebellar stroke, and
Read for me. When the sunlight strikes raindrops in the air.
There is nothing that you can do for her except to send her for speech therapy, and even with speech therapy, it's very hard to rehabilitate the voice. You can't help everyone. So in conclusion, care of the patients with voice needs a dedicated team. Some disorders fall into the gray areas, and some of these disorders can overlap. Some are not clear at the first visit, and you need multiple visits before a firm diagnosis is made. And sometimes you need a trial of treatment before a marked improvement is made. With that, I thank you very much for your kind attention, and I want to refer to a question that was posed to the team yesterday by one of the participants who wanted to know the difference between muscle tension dysphonia and spasmodic dysphonia. Now, muscle tension dysphonia, if you can remember, is characterized by hyperadduction of the supraglottic muscles of the false cord, and it is characterized by hoarseness and pain. Whereas spasmodic dysphonia, the phonics, if you look into the endoscopic examination, would be normal. You will not get the hyperadduction of the false cord. There'll be no pain, but there's a break in the flow of the speech. Okay, so they are quite distinct entities. Although I do admit, sometimes what you think is spasmodic dysphonia, after multiple visits, you think, okay, I think he's got mild spasmodic dysphonia, and therefore we still inject Botox, give Botox a try. Okay, with that, I thank you so much for your kind attention.
Thank you so much, Prof. So always a pleasure to listen to Prof's talk. You never fail to interest us with all those mimicking of the different voices, pathological voices and speech. So our next speaker is Professor Dr. Marina Baki. Dr. Marina Baki is a professor and senior consultant of otorhinolaryngology and head and neck surgery at University Kebangsaan Malaysia, Kuala Lumpur, Malaysia. And she has 14 years experience teaching both undergraduate and postgraduate students, and Dr. Marina subspecialized in laryngology and was awarded PhD in laryngology from the University College London in November 2014. She has spoken in various national and international conferences and has over 60 publications from the Web of Science core collection. Professor Marina will be speaking on stroboscopy and enhanced imaging. So please welcome Professor Marina.
Thank you, Professor Mawada. Is my voice okay, loud and clear?
Yep.
Okay, I will share my screen now. Thank you for a very kind introduction, Professor Mawada. So the topic that I'm going to talk about is on stroboscopy and enhanced laryngeal imaging in diagnosing vocal pollutions. All right, so this is the building of University Kebangsaan Malaysia Medical Center. The blue color building is Biomolecular Institute, the Institute of Research, and there's another preclinical building next to it. So what are the learning objectives of this talk is, number one, for us to know what are the recent advances in endoscopic imaging technologies. So we're going to talk about video laryngeal stroboscopy and enhanced imaging, the two things here. And number two, to understand about the principle and assessment of video laryngeal stroboscopy. And number 3, to understand the clinical applications of the both advanced laryngeal imaging, the video stroboscopy and enhanced imaging. So the content of the lecture, first I will briefly talk about protocol of voice assessment, basic protocol. What is the basic principle of stroboscopy and enhanced imaging? And number 3, how do you assess stroboscopic findings? And I would show 2 or 3 case demonstrations that may help us to understand more about the use of this technology. So for basic protocol of voice assessment, it is important for us to assess the voice subjectively and objectively because it helps in treatment effect monitoring. It also helps in surgeons when they want to communicate about certain patients, and it will allow for meta-analysis later on when we want to compare results of different surgical intervention or different treatment. In Philippe de Joncker et al. Had published a guideline on what is considered as basic voice assessment in patients with voice disorder. And these are the voice evaluation. I just briefly mentioned one by one. Number 1 is voice specific patient self-reporting outcome, which the one popular is voice handicap index by Clark Rosen. This is patient answering questionnaire and assessing how much the voice disorder affect their life. Number 2 is voice perceptual evaluation. This is done by ourselves, otorhinolaryngologists, speech language pathologists, and the common scale that been used is the one that introduced by Hirano. We call it GRBAS, G for grade, R for roughness, B for breathiness, A for asthenia, and S for strain. Next is an aerodynamic analysis, and the cheapest and the easiest way is by measuring the maximum phonation time. And another one is objective analysis. This is optional, but if you want to publish your results, it is better for you to have this, the computer-based analysis of the voice. And what we're going to focus on today is on video laryngostroboscopy, which it allows us to examine the vibratory characteristics of the mucosal wave of the phonating vocal fold. So just to share with you, maybe you want to check this out. We have published the Malaysian version of the voice handicap index. Whoever wants to use in the clinic formulation, you can access this, published in Journal of Voice. And the maximum phonation time, the normative value for the Malaysian and for the Asian, as well as the correlation between the maximum phonation time and the body mass index. Now, we're going to focus on the laryngostroboscopy and enhanced imaging. So first of all, what is stroboscope? It is an instrument that makes cyclically moving object to appear slow moving or static. So stroboscope consists lamp that can produce flashes of light on the moving object. The timing and frequency of light is adjusted according to the frequency of the moving object. In 1878, Ortel pioneered the use of stroboscope in laryngology. So in other words, stroboscope is not just in laryngology, but has been used in other fields as well. This video, I got it from the YouTube to demonstrate how the flashes of light make this like a fan can be seen as slow motion. So when the fan is played, so when it is very fast, you wouldn't be able to see the blade. But whenever flashes of light is emitted on the moving blades and the frequency delayed by a few seconds, you can see the blade moving slowly. So the same principle is applied on the vocal cords. So for normal vocal folds, it vibrates during phonation. It can range 70 to 500 hertz in males and 130 to 1000 hertz in female. So it means that, for example, if it is 250 hertz fundamental frequency, there would be 50 glottal cycle within 1 second. So therefore, to visualize the vibration is impossible using naked eye. So we need the stroboscopy to examine the mucosal wave. Why is it important for us to examine the mucosal wave or the vibratory characteristics of the vocal folds? It is because by examining this, we can examine the health between the superficial mucosa, which is the cover, and also the body, which is the vocal fold muscle, and also the in-between of those structure is the intermediate layer that consists of the intermediate and deep lamina propria. So this is the system that we use. It is by Pentex Medical who sponsor this webinar today. So you look here in the stack, there is a stroke processor. This is the processor that can produce flashes of light. So how the stroke processor decide what is the frequency of light that should be emitted on the phonetic vocal fold. So it can be informed, the laryngeal stroke processor is informed about the frequency of patient's voice using the microphone and pitch tracking. So therefore, when we perform stroboscopic examination, it is important to put the microphone at the neck of the patient. Therefore, the frequency of the patient's voice will be emitted informed to the laryngeal stroboscope processor. Therefore, the flashes of light is decided. So in a strobe processor, you can see the frequency of the patient's voice here. Now, just now I talked about video stroboscopy. Now I'm going to touch a little bit on enhanced imaging technique. And later on, I'll show you how these two can be merged together. So the recent advances in endoscopic imaging technologies consists of high resolution and digital chromoendoscopy, which are primarily available in two systems. So this is a technology that can enhance lesions and vessels of the larynx and vocal fold. So first, one system is called pre-processed system, which is popular is NBI, narrowband imaging, in which in this system, the white light, certain wavelength is narrowed. So the wavelength is shortened, mainly two wavelengths, blue and green. So therefore, the penetration is different. So therefore, the mucosal lesion is enhanced and the blood vessel is enhanced. Because the bandwidth is involved blue and green light, so the image look green. The other system is called post-process system, which in this system, it doesn't narrow the bandwidth, but it modifies the white light by enhancing the contrast and make the vessels and the lesion look more prominent as seen in this picture. So this is not green and light, it is still red, but it is more enhanced. So the latest technology, the second one, which is post-process system, is called iScan, and it is an adjunct to the traditional white light. So in this technology, there are three modes of image enhancement. I'm not going to talk more detail about this, but what I want to tell you that this technology can be combined with stroboscopy whenever we examine the patient's vocal fold. This endoscopic imaging technology and video stroboscopy is a complementary tool in evaluating in early vocal fold lesions. Another thing that I want to talk about is the choice of endoscope. You can use rigid scope or you can use a video endoscope. I personally prefer video endoscope because you can bring the tip of the endoscope as close as possible to the vocal fold for the examination. And this is the system that we use. What I'm not selling the system, but I just want to make you to understand that here on this top stack, this is the white light that consists iScan as well. And the second stack, this is the stroke processor, which can be combined when we examine the patient. So you can understand the video that I'm going to show later on. So when we are talking about enhanced imaging technology, there is a proposal which give a guideline how we can use the enhanced imaging technology in examining the vascular changes and how does it help in the diagnosis of vocal fold lesions. So this is proposed by European Laryngological Society. The classification consists of type 1, 2, 3, and 4. For benign is mainly type 1 vascular changes. 2, 3, and 4 is basically for precancerous or malignant tumors. So just briefly, I'm not going to talk detail about this. This is the view diagram that shows a normal vocal fold over here with longitudinal vessel. And once someone have lesion on the vocal fold, the vessel become perpendicular from the base. So therefore, when you scope from the top, you would see a punctured lesion or a spiral lesion, and as it becomes spiral and more bizarre, it indicates we are dealing with vocal fold malignancy. So this is an example, a patient with leukoplakia, and you can see dots from the top. This happened to be a high-grade dysplasia. And another one, patient with vocal fold mass, and you can see spiral-looking, bizarre-looking vessels that indicate this patient has malignant tumor on the vocal fold. Now we're going to talk about stroboscopy findings assessment. How do you assess stroboscopic findings? So the evaluation is primarily subjective in nature. However, there are certain tools that we can use to help us in documenting and standardizing the way we assess the vibration of the vocal folds. For example, this is stroboscopy research instrument developed and validated by Clark Rosen. Here, every time you see the phonetic, the vibration of the vocal fold, you document whether the mucosal wave, is it symmetrical? What is the amplitude like? Is it normal or abnormal? Is it periodic and not? Is there any non-vibrating segment? And what is the duration of closure within one glottal cycle? So when I'm talking about glottal cycle means, when talking about close, open, and close again, that is considered as one glottal cycle. So for example, someone who has 250 Hertz fundamental frequency means there is 250 glottal cycle within 1 second. So there's one way we can look at the glottal cycle is by using montage in the system. Whenever you can do frame-to-frame analysis, this depict close place, open phase, about 3-4 frames, and then close again. So this consists of one glottal cycle. Now, just briefly, what does it mean by symmetry? The mucosal wave is considered symmetrical whenever it open at the same time, mirror image. The amplitude is the same and it closes at the same time. So we call that a symmetrical mucosal wave. And if the wave is periodic with a certain tempo, it is not jittery, we call it periodic symmetrical mucosal wave. And what does it mean by amplitude? Is by looking how does the mucosal wave move horizontally from the midline laterally, the excretion of the mucosal wave. So the amplitude would be reduced in someone who have vocal fold stiffness or someone who have tight glottic closure, for example, in hyperfunctional dysphonia. And here in one glottal cycle, if someone have like 3 or 4 open phase and the rest is closed phase, this is considered predominantly closed duration of closure. Just briefly, you have to read up about it if you want to understand more. So now we come to the more interesting part, which is the case demonstration. For the case demonstration, a first case is a 23-year-old female college student who complained of hoarseness for 1 year. The first time when I saw her, I used a fibroscope to examine her. And then we can see this lesion on the vocal fold. Okay, we kind of see two lesions on both sides of vocal fold. Therefore, at that time, the diagnosis was vocal fold nodules and she was sent for speech therapy. 2 months later, there's not much improvement of the voice, and now we use video stroboscopy. Say E for me, long E. Do me a little long E. So I hope you agree with me. Now the diagnosis change. It's not actually vocal fold nodules. It is left vocal fold polyp with reactive lesion on the opposite side. So this is a montage of glottal cycle. You can clearly see that the polyp on the left vocal fold, reactive lesion on the opposite side, and there is no complete closure. It is hourglass type of closure, and within one glottal cycle, the duration of closure is predominantly open. So that's why the patient complained of vocal fatigue. So the diagnosis changed and ELMS is offered to the patient. Another case demonstration, a young woman, non-smoker, hoarseness for 2 months. And this is the endoscopic finding. So just now on white light, now on eye scan 1, you can see that the abnormal irregular mucosa is more enhanced on the enhanced imaging, eye scan 1, eye scan 2, and then eye scan 3. And when we change the light into stroboscopic light, you can appreciate that there is no mucosal wave on the opposite, on the irregular part, on the lesion, which is on the right vocal fold, whereas the opposite vocal fold, there is mucosal wave. So considering this is a young woman, no history of smoking, and 2 months history of hoarseness, we took a biopsy with precision technique, and it turns out to be tuberculous laryngitis. And 2 months after the treatment, we can appreciate that there is the irregular lesion of the vocal fold has reduced. And when we change to eye scan, you can see that the irregular mucosa has reduced. And when we change to stroboscopy, I hope you can appreciate that the site that has no vibration now has some vibration, and the vibration is returning. So hope this is clear to you. So that's how we can, the stroboscopy help with the diagnosis. I think this is the last case demonstration, a 40-year-old chronic smoker who abused his voice a lot. He's a chronic smoker, 40-year-old. One look at it, maybe we think of malignant tumor considering that the patient is a chronic smoker. However, when we use the enhanced imaging technology, we notice that the vessel is type 1. This is what depicted in the paper is type 1. So if I show again the same patient, this is the lesion, and you can see the vascular is horizontal, longitudinal, rather than perpendicular. So the diagnosis of this patient is hemorrhagic vocal fold polyp, confirmed with a histopathological examination. So in conclusion, video laryngostroboscope is important tool in assessing vocal fold of patients with voice disorder. When we combine laryngoscope and stroboscope light, you would be able to examine the mucosal wave of the vocal fold. And patient cooperation will be improved if we use a video endoscope rather than rigid scope. And combining stroboscope with enhanced imaging technology will make your diagnosis more accurate. With that, thank you so much. Sorry if I take time longer than supposed to.
Not to worry, Professor Marina. We enjoyed your talk, and we are on time. So after the 3 amazing lectures by the speakers today, it's time to have some reflections or comments by other panelists that's available today. So the first panelist for today is Professor Dr. Muhammad Zulkifli Abu Bakar. Professor Dr. Muhammad Zulkifli is a senior consultant and professor in otorhinolaryngology and head and neck surgery, University of Malaya, Kuala Lumpur. So he pursued further studies in London and Memorial Sloan Kettering Cancer Center in New York, and he is currently the Deputy Director of University Malaya Medical Center. Despite being busy with his clinical work, he is still actively teaching both undergraduate and postgraduate students and mentoring head and neck oncology, laryngology, and AV surgeries. So Professor Dr. Zulkifli will give his comments on the 3 lectures that we have listened to today. And I invite Professor Dr. Zul to talk for about 5 minutes. Prof. Zul, you can unmute your microphone.
Sorry. Okay. Thank you very much, Prof. Mawa. Thanks again, Prof. Marina, for inviting me for this excellent webinar. Okay. We had an excellent lecture, conference lecture from Dr. David, Prof. Sani, and Prof. Marina, what I can conclude that from 3 lectures, we need to achieve precision diagnosis as well as treatment in those having voice problems. So in order to have an excellent voice center, so one need to have a stroboscope plus eye scan, of course a laser machine, and a speech pathologist, and with the great training laryngologists also, we need to be available at any time. And most importantly, we also need good NS backup for those cases need to have a jet ventilation or proper anesthetic mode for any lesions need to be clear up. So this anesthetic anesthetists must well versed in terms of airway backup. So let's say, okay, you don't have all these machines, all these kind of expertise in your place. What do you have in your mind or in your area, I mean your premise, in order to continue having a service, laryngo service? However, you can't challenge all this, I mentioned just now, like what we call it stroboscope, eye scan, and laser. But in your place, if you have you don't have still waiting for the approval from management in terms of money, and this costs a lot of money. So I think at the moment what you should have video laryngoscope with autofocus. That's another tool that you can use in the clinic rather than simple flexible scope that you routinely use, because it tends to have a blurry vision and then not nice, because a lot of sometimes secretion that obscure your actual diagnosis. So if you while waiting for stroboscope eye scan, probably you need to have video flexible scope with autofocus. That's very good tool actually in the clinic. Whereas for in the OT, micro instruments, you need to have in the OT in order to remove some benign lesion, as well as to get proper diagnosis, especially in those suspicious lesions. So these all things that I think otherwise we have a very comprehensive lecture, then I think you can practice in your place. With that, thank you very much from my side.
Thank you, Professor Zul. So I would like to invite our next panelist, which is Professor Dr. Masani Mansor. Professor Dr. Masani Mansor, if you can give some comments regarding the lectures, or perhaps anything that differs in your practice, that would be great. So I'd like to introduce Professor Dr. Masani. Professor Dr. Masani is a consultant in laryngology and head and neck surgery in Faculty of Medicine, UiTM Sungai Buloh. And Dr. Masani has completed her postgraduate studies in University Kebangsaan Malaysia itself, and she has completed the subspecialty training in Ministry of Health on head and neck and laryngology, and she's also a research fellow of Harvard University in 2012. So Prof Masani, if you could share with us any of your thoughts on the 3 previous topics that was delivered by our speakers just now.
Hi, Assalamualaikum and good evening to everyone. Wonderful talks, very comprehensive. Now, when it comes to laryngology, I suppose it's a very specialized area, and based on all the talks, I think the most important thing is getting the correct diagnosis. So in order to treat, the correct diagnosis has to be obtained and then followed up by treatment. So in my opinion, if we misdiagnose, we can cause permanent damage to the patient. For example, operating on a person or operating on vocal folds that are not supposed to be operated on, which can cause scarring, and that's a big no-no in among laryngologists, because it's something that is next to unrepairable. So that's my comment. And I'm sure that for all those out there who are in doubt of their diagnosis, we here more than open for them to come and ask or inquire about the cases. I'm sure we're all helpful in that way, so that no mismanagement will be done to the patient. That's all from me.
Thank you, Professor Masani. So we've got some open questions for Dr. David. So the first question was emailed to us, Dr. David, asking regarding your thoughts on recurrent or recalcitrant vocal nodules. How do you manage these if, let's say, the patient has gone for speech therapy? And can you please enlighten us with some tips, perhaps, if, let's say, you may want to consider surgery in these patients?
So we're talking about vocal nodules that don't seem to be responding to speech therapy.
Yeah.
The first step is to find out whether the therapy is being done correctly and whether the patient is misusing their voice in any other ways. We need to kind of go through the whole conservative approach in detail one more time, or even 2 more times, or even 3 more times. And we need to try to really avoid doing surgery for nodules. I do have a short video which I can show you where I did operate on what appeared to be a nodule, and if you like, I can show you that. Would that be appropriate?
Yeah, that's appropriate. We still have time for that. Thank you.
Just allow me to try and share my screen again.
Yeah.
Okay, here we are. Okay, so hopefully this will play.
Dr. David, can you put that onto slideshow mode?
Yes, I'm about to do that. Sorry, there's a lot of Zoom boxes all over my screen.
So sorry about that.
That's okay. I'm just getting rid of them. Okay, so if you look at the picture on the left again, longer. That you see that there is some sort of swelling of the left vocal fold here, and there is a corresponding swelling on the opposite side. So you could say that this could be bilateral vocal nodules that are rather soft looking. You could say that it is a left-sided polyp with a so-called contralateral thickening, or it could simply just be a left-sided polyp. I'll just play the rest of the... And the other important thing that you see here is that the patient is unable to close their vocal folds. So the polyp seems to be doing something that is stopping the vocal folds from coming together. So they're using it as the vibratory surface. So in this patient, this patient didn't respond to speech therapy, and I actually did surgery to do the excision. You have to be very, very careful when you're doing this surgery. You do not want to damage the deep tissues at all. I think I have a post-op. One more. Okay, so you can see that the vocal folds now touch, they vibrate very smoothly. And in this situation, surgery is appropriate. But the rule of thumb is that for vocal nodules, we cannot just give one round of speech therapy and say that's not working, let's do surgery. That is not the correct approach. We have to revisit the whole concept.
Brilliant, brilliant. So Dr. David, when doing surgeries in vocal fold nodule, there was another follow-up question here from the question and answer box. Do these vocal nodules tend to extend to the deep lamina propria?
The answer is typically no. So a vocal nodule is typically an epithelial lesion, and the excision should be limited to the epithelium.
Okay, thank you. There was another question. I know Dr. David has answered a lot of questions on the Q&A box, but it keeps on coming.
Yes. Can I respond, please? Prof Mawada, can I respond? Thank you very much. Okay, Dr. David, a long time ago in a galaxy far, far away, we were always taught that nodules should be treated conservatively by speech therapy and so on. But over the years, I've changed my mind about this. I would give the speech therapists about 4 months, 5 months, and after 6 months, if there's still no improvement, I would gladly do surgery for the nodules. For some reasons, for two reasons. Number one, if it doesn't work with 6 months of speech therapy, it won't work. The patient just cannot understand the instructions, or I have children. Of course, they can't understand the instructions by the speech therapy, and I would gladly operate, but you must be judicious. You must be very careful in this operation. I've done the operation, and this operation seems to break the cycle, and they get a normal voice, and then now they appreciate this is normal voice, and I must take care of this, because otherwise Prof Sani will operate again on me. So that reinforces the fact that they must not abuse the voice. And now, personally, I'm more open to surgery for vocal nodules, much more than before. Before I used to, no, we won't do you, it's never done and all that. But now I'm more, okay, 6 months, okay, fine, let's do it. And I think maybe there's, people can try. I mean, as long as you don't damage the cords, you can try.
I think, Prof Sani, I do not disagree with performing surgery for vocal nodules, but my take-home message for the participants here, I think, is very important, particularly in children, for example. So we may have the nodules, it may break the cycle, but in kids particularly, I believe we have to be especially careful. Believe me, I'm very happy to operate on them. I think I can do a decent job. But what I'm very concerned about is the recurrence of, if the factors that cause the nodules are not dealt with correctly, then the nodules are likely to come back over time. It may be 1 year, 2 years, 3 years. We may never see the patient again, and we may think that everything is fine, but it doesn't mean that the problem has gone away. So this is just for the participants, but between you and me, I think we have the same thinking.
Yep.
I wish to say something about nodules as well, Prof Mawada. May I?
Yes, please.
Okay, so yeah, great discussion about vocal nodules. I just want to add here is, I found that many patients who come with vocal nodules, especially the youngsters, they do have chronic post-nasal drip due to allergic rhinitis, which the chronic post-nasal drip cause chronic laryngitis, thus predispose this patient to get vocal nodules. And I found that other than speech therapy, tell the patient about vocal hygiene, and you treat intensively the allergic rhinitis, it really helps to treat the vocal nodules. Yeah. And you may not have to do surgery at all in this patient.
Yeah, so you have to treat the underlying conditions that may be related to the vocal nodule itself. So we have another question on vocal polyps, since we've already shared just now with some vocal polyps which may respond to intensive speech therapy. So perhaps, Dr. David, would you like to share with us what kind of polyps do you think that will respond to intensive speech therapy, and which ones would rather end up with surgery?
Okay, so I think that's a somewhat difficult question to answer, because we may look at the polyp and say, well, this one looks rather soft, and therefore it may resolve by itself, and we give it more chance to do so. Or we may look at the polyp and say, this one looks very organized, and I don't think this is going to resolve. Let's do the surgery, and so on. And I'm very happy to do the surgery. But it just so happens that some of the patients come along and they say, well, I say to them, I think this would benefit from surgery. Maybe we get a diagnosis, we'll cure your problem just like that. And all you have to do is 2 weeks of voice rest. And they say to me, no, I don't want to do it. Give me more time. And what do I need to do? So I tell them, look, you have to stop speaking for 2 weeks, and you have to stop clearing your throat and all of these things. And these patients go away if they actually do what you tell them to do and they manage their reflux. I have had polyps that I thought would never go away that actually went away. After 3 months, they got smaller, 6 months it disappeared. And that is the sort of time frame that it may require.
Okay, cool. So we can continue on with conservative management for about a few months, then we'll see how it goes. So we've got one participant who have raised up their hand. I would like to allow him to perhaps present his questions live. We have Dr. Lam Saiguan. Do you want to present your question live? Dr. Lam? All right, if Dr. Lam is not, I've permitted him to talk, but are you having problems, Dr. Lam? Okay, if there is no question from Dr. Lam, so we have another question at the chat box now. It's regarding how to differentiate soft and hard nodules, and does it affect the management? So perhaps I can pose a question to Professor Marina. Would you like to answer that?
Thank you, Prof Mawada. So how you can differentiate that if you don't have stroboscopy, by just using fiber scope probably difficult, but if you have a video endoscope like Prof Zo has mentioned, something like autofocus, you can see the thickness. Okay, in a hard nodule normally it is thicker, and the soft nodule it is just like a bump at the middle edge, the free edge of the vocal fold. The hard nodule normally it is thicker and probably wider, yeah, compared to the soft nodules. I've seen that in one patient who is a senior. She has soft nodule. You can see like just a little bump, but she can't go high range, and we can see that she tend to get hourglass closure. With speech therapy and then treating her allergic rhinitis, the soft nodule disappear in about 2 or 3 months, and voice rest as well. But another case, a child of 12-year-old who abused his voice a lot and have very bad allergic rhinitis with post-nasal drip and a lot of secretion. The nodule is not just at the middle edge of the vocal fold, until I think that we may actually dealing with infection, because it's like wide and thick bumps at both sides of the vocal fold. And because of that, we took a biopsy with precision technique, of course, to ensure that this is not something else. Okay, and it turns out the HPE is nodule, and the site that we have removed, what do you call that, resolved quicker than the opposite side. The opposite side eventually resolved as well with time, with a speech therapy and allergic rhinitis treatment. So I think in hard nodule, normally, if it is recalcitrant to speech therapy and medical measures, the answer is we have to do surgery, but with precision technique, like Dr. Lau had described, using micro instrument and high magnification, so that you respect the layers of the vocal fold.
Thank you, Prof. Marina. There's another question in the Q&A box regarding in muscle tension dysphonia, how can you assess the false chord if it's in the way by stroboscopy? Marina?
Mawa, can I add something on the hard and soft nodule?
Yes, please.
Yes, I want to share regarding the surgery for the nodule using laser. During my attachment with Guri Sandu, he do this technique of missing the spot techniques. In this technique, you have to use laser, and you start pointing the laser away from the nodule first, and then you just use the laser and just miss at the edge of the nodule and go from medial, you put the is it missing the spot techniques, means that you didn't put the laser directly on the nodule itself, but you start from medial and you go laterally to the nodule. So in that techniques, you actually didn't hit the vocal cord on the nodule itself, but it was a very precise technique. I think it will help, but you need to have laser to do this technique. Yeah, thank you. Sorry.
Thank you for the comment. There was another question by the participants just now is regarding essential tremor and propranolol. So the question was posed by a doctor from Vietnam. So if I can have any of the panelists who wish to give input on the effect of propranolol in patients with vocal tremors, you can give your input.
Can I give some input first?
Yes, please, Dr. David.
So I have used propranolol to treat vocal tremors. I have given high doses. I have given I think up to 40 milligrams TDS, and patients don't like it. They get very tired. They get a bit hypotensive, and to be honest with you, I have not had huge success with propranolol for the vocal tremors. So it's worth a try for a short period of time, but not typically. I find it doesn't work that well.
Yeah, I have one patient with secondary tremors, which is secondary to Parkinson's. She too did not respond to propranolol. In fact, suffered from hypoglycemia from the side effect of the propranolol. So any other panelists would like to give other inputs, perhaps a success story on propranolol? Okay, since there's none, so we would like to conclude the question and answer session for today's webinar. So we will move on to the case discussion. Don't worry, you can still post the questions on the question and answers chat box. We will still respond to your questions, but it's just via texting or just writing up the answer. So we'll move on to the next section of the webinar. So we will do some case discussions, and today we've lined up for you 3 cases to be discussed. Let me share my screen. So we'll go to the first case for today. So the first case is a 16-year-old Malay male who developed depression following a voice problem. He was brought initially by the mother, who is a very adamant lady, very disciplined lady. She couldn't accept that the child had voice problem and is not manly according to the mother. Yeah. So this male student developed depression and find himself not enjoying school, and later was uneasy to talk in front of the class, and this was associated with absenteeism for a total duration of 6 months. He was studying in Form 4 back then. So this is his voice.
Kampung bersama nenek. Ayah dan mak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan mak. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak dan adik datang menziarahi kami di kampung.
Okay, so perhaps I can have Professor Dr. Masani. I know it's very typical of bubophonia. Prof Sani has talked about this, but since there are many psychological issues surrounding this patient, what are your pearls or tips in approaching such case?
I think first we need to counsel. The mother needs to understand the pathology. Maybe refer the mother and son to counselor, because the mother's support is very important in his recovery. Number 2, for bubophonia, usually the management that I've seen is by speech therapist. In Boston, they used laryngeal massage, but I have not seen it done here by the voice therapist, whereby by the time the patient comes up from their session, the neck will be like black and blue altogether, but it actually works. and the voice therapy that is given is intensive. It's not like far away in between sessions, and the patients do well with this intensive voice therapy. That's what I've experienced, which is a bit difficult here back in Malaysia.
Yeah.
That's from me.
Thank you, Professor Masani. So I think Puan Sharina wants to have a talk. Yes, Puan Sharina. Puan Sharina is our speech language pathologist from University Kebangsaan Malaysia.
Just to add on from what Prof Masani said just now about the intensive, yes, I find that for voice therapy, patient do need to see the minimum once a week on weekly basis. You can get twice a week to start with, because it involves change in behavior. Yeah, so that's the thing. It's just that sometimes some patients say they have some challenge, but usually what I would do is actually I would tell them this is a commitment. If you're not ready, then you can, maybe we can start off with something, we don't really practice therapy yet, so sometimes patients would delay it a bit, then we would need to start on a weekly basis before do it fortnightly for maintenance.
Okay, so we've listened to issues such as psychological support as well as intensive speech and voice therapies from our panelists. So in fact, these are the concerns or focuses in management that we had when we saw this patient. So in fact, on the first visit, I saw this patient during the pandemic, so that is why he's wearing his masks on, and it was difficult to find speech therapy sessions. So we had to delay our management in terms of speech therapy. So I ended up exploring the psychological issues surrounding this patient more, so that he can accept his condition more, as well as the family to be supportive of him, of his voice problems. So on the first visit, we managed the psychological problems, why he had depression. We went through all the factors with him, and on the second visit, he admits to have low mood, but apparently he thinks that it's not solely contributed by his voice problems. Apparently he feels the pandemic itself has caused social isolation onto him, and that is why he's feeling depressed, and he's getting very mad at his family and siblings, just because he feels that it's easier for him to be alone, being socially isolated, in this pandemic situation. So this is him on the second visit. Bear in mind, I didn't do any speech therapy. I just asked him to breathe, take care of his voice hygiene, abdominal breathing, relaxation, and so forth. So you can listen to him.
Masa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, emak dan adik datang menziarahi kami di kampung. Saya gembira apabila mereka datang kerana saya boleh bermain bersama-sama abang dan adik. Di belakang rumah ini ada sebatang sungai itu. Begitu juga saya tetapi tidak boleh bermain di sungai. Dia masih kecil dan belum pandai berenang. Setiap pagi abang dan saya pergi ke sungai. Kadang-kadang kami lupa makan dan minum.
Okay, so if you listen to this video, there are two parts of the video. The first paragraph, he was using his high-pitched voice, but there were some breaks of normal voice that you can listen to. That it's not really pitch locked at high pitch. Yeah? So and on the second paragraph, he now realized that he can use his male voice, but he was not too comfortable using it. So when he realized his problem, he's able to accept that he has psychological issues following these voice problems. I feel that he has adjusted to a certain extent, yeah. And then of course the rest of the therapy is done by the speech therapist, and I would like to pass the microphone to Puan Sharina, and she would kindly explain to us what she has did to this patient.
Thank you, Prof Mawada. Okay, this patient actually.
Masa saya kecil.
Sorry.
It's okay. Okay, this patient came to see me last week, and from the case history, he actually already have his male voice since 2 years ago. but the reaction that he received from the mother, especially, was not motivating, was not positive enough. So he actually decided not to use. So I didn't really do much of therapy specifically to target for the pitch, but because he actually he's able to do both high and low pitch voice. But what we did is actually, the aim is to get him to establish that voice and use. We managed to label both voice, so he was able to identify the high pitch voice associated with a female voice, but he prefers to name it as Ahmad voice, and another one is the second name, and he's able to change. And we talked through and about the situation that he prefers to use first the man voice, and in any situation where he's not ready, then he would actually go back to the old voice. So there's a lot of acceptance in terms of his conflict to get people to recognize him with his new voice, with his man voice, the appropriate voice. He knows that that is the appropriate voice, but because of the acceptance and how people react, because it sees differently, it doesn't fit him personality, because he's a little bit he's actually in the soft side, so he's not comfortable, and he finds sometimes it a little bit conflict with his personality. So yeah.
Thank you, Puan
So I'm going to
Sharina.
see. Yeah.
Sorry, Puan Sharina.
I'm going to see him next week.
Thanks. So if any of the panelists, the rest of the panelists would like to give comments on this particular case, you're free to do so.
My question would to Prof Sani, because I'm not that good in functional voice disorders. Would you categorize this as purely pubophonia or conversion?
Yeah.
Correct. So we must ask, or we must find out, it is pubophonia, primarily it's pubophonia, but we must ask the patient, we must find out from the patient whether does he have a gain. What does he gain more? Does he gain more by the high pitched voice, or does he gain more by the normal voice? You know, but if he gets more gain, he feels that if he gets more gain by the high pitched voice, which is not normal, then it is a conversion disorder. And if he gets and what is his wish? And then that's the real. That is what we really come down to, you know, Prof Mawa. What does he want? Does he want a high pitched voice, or does he want a low pitched voice? What does he want? He wants a high pitched voice. He's happy, and that's fine. Does he want a normal adult voice? So it's what he wants. Yeah, he can be both. Maybe he can be both. He at home he wants to be high pitch. At the school he wants to be low pitch. You know.
Yeah,
There's no rules.
Yeah, there's no rules. He is to decide which one he wants, I think, and we should provide the avenue for him so that he's not psychologically burdened. That's my thoughts. But of course, I did some research on him and his use of voice. So he's a very active user of Instagram, and he usually posts videos of him telling about things, giving advices, and so forth. And he will use his male voice. So I know deep inside he know that the male voice is socially acceptable, and therefore he will continue to use the male voice. But he also have other things in his mind, because when it comes to singing voice, he would like the higher pitch voice compared to the male voice. So I think these are some of the issues surrounding the patient. I don't think the patient has conversional voice disorder, because the patient has nothing to gain from this. In fact, he's losing from this voice problem.
May I add a comment?
Yes, please, Dr. David.
I have one little trick that I sometimes use. And this was described by Murray Morrison in his book in the 1980s. So he has 4 types of muscle tension dysphonia. The type 1 is when the vocal folds open at the back. The type 2 is when they press too tightly. Type 3 is when they compress anterior to posterior. Type 4 tends to fit with the conversion dysphonia. And typically what we see is that the cords are stretched and elongated, and they tend not to come together completely. So there tends to be a small gap there. And that can be one way of at least thinking about the diagnosis.
Thank you, Dr. David, for the tip. So I would like to pass the microphone to Professor Dr. Marina, who will bring us to the next case.
Thank you, Prof Mawada. We'll share the screen. Sorry for the a little bit delay. There's some confusion about my PowerPoint.
Not to worry.
I'm there. I'm there. Right. Share the screen. Okay, I'm going to share a case. Okay, this is a 25-year-old female, previously healthy, and she complained of sudden onset of dysphonia for 2 weeks. Sudden onset of dysphonia, and she claimed that she had that after watching a K-drama at night. And then the morning when she woke up, her voice becomes severely dysphonic. Otherwise, she doesn't have any other significant history for swallowing or breathing disorder. And there is no shortness of breath. Sorry, Pramawada, can you still hear my voice?
Yes,
Hello?
I can hear your voice. Yes,
Okay,
we can hear
because-
you.
Sorry, because I can hear that my AirPods is losing the battery. Okay, so and this is actually the second episode when she had this problem of acute onset.
Prof, we are losing you.
Yeah, you lose. Okay, hang on. Yeah, sorry. I need to remove my AirPods. And then, can you hear my voice now?
Yes, loud and clear.
Okay, so I don't have to use my AirPods then. So she had similar episode 8 months ago, and it lasted for 10 days. And she claimed that it resolved after she was given antibiotic by the GP. And she had multiple history of laryngitis for the past 8 years. And each episode she has to go to the GP, and then symptoms resolve with antibiotics. And she also has some symptoms suggestive of laryngopharyngeal reflux. She worked at the staff nurse, so voice demand is moderate. There's no other significant history like suggestive for any predisposing factors for vocal fold lesions. And this is her past medical history, allergy, nothing is significant. Okay, she's a non-smoker, never consumed alcohol, and this is her voice. Okay. Can you hear the voice, Pramawa?
Yes, we can hear the whispery voice.
Here to listen, hear her voice. Very hard to hear her voice. I think it's like whisper type. And so if I do the voice assessment on perceptual voice evaluation, I would say overall dysphonia of grade 3 with main component of breathiness and asthenia. And her quality of life is really affected when the VHI-10 33/40, significantly high. Reflux symptom index is not significant, 7/45. Surprisingly, the maximum phonation time is not too bad, 13, it just slightly reduced. On acoustic analysis is all the range, the fundamental frequency, jitter, shimmer, and noise to harmonic ratio. And this is a video laryngostroboscopy combination with eye scan. And this is a stroboscope. Okay, so that is her voice, voice assessment and video laryngostroboscopy. So I would like to ask opinion from the panelists. Probably from David. What do you think? What's wrong with her voice and vocal folds? And how would you manage this patient?
Okay, so can you hear me?
Yeah, I can.
Yep,
Okay.
David.
So my first comment is on the GRBAS score. I noticed that you put S0. I would have put S at least 2 for her. So she sounded very breathy. I agree with the breathiness of 3, yeah. But I think at the same time she was also very strained.
Okay, agree.
I maybe some asthenia as well, but I think she was strained. When we look at her larynx, her vocal cords look pristine, other than a small varix on the left vocal fold. Both vocal folds are mobile, so she doesn't have paralysis. And during phonation, she has what I would call a very severe type 2 muscle tension dysphonia. In other words, the cords are not just coming together, but they are getting squeezed in a sort of Y shape by the supraglottis. So I think she has a form of muscle tension dysphonia. I would ask my speech therapist to come and have a look at her and just see how amenable she might be to speech therapy as a starting point.
Brilliant. Thank you, David. Very nice description of the classification of findings on the vocal fold during adduction. Prof Sani have given lecture on functional. Do you have anything to add, Prof Sani?
No, I think this is a very difficult case, you know. But when we have to sit down and we need to speak, we need to spend time with the patient to overcome this problem. No, I do not have anything to add. I'm sure that we need to refer to the speech therapist. You know, I'm sure that we need to refer to the speech therapist.
Okay, thank you, Professor Sani. So yeah, I agree with David. The diagnosis is muscle tension dysphonia, but I would add primary at the front because as Dr. Lau said, that the vocal fold look pristine, except there's one ectatic vessel on the left, the midcord of the vocal folds. And the mobility is normal, so we're not thinking of any neurological origin, the structure all pristine, so we're thinking of primary muscle tension dysphonia. With a differential diagnosis of psychogenic dysphonia and conversion dysphonia. So probably here I want to ask Sharina, how can you differentiate between these three, the primary, MTD, psychogenic dysphonia, and conversion dysphonia?
Thank you, Prof. Marina. That is a little bit tricky because muscle tension dysphonia could be the predominant features for the psychogenic, and conversion dysphonia is the extreme effect of the psychogenic. But typically, patients with conversion dysphonia, they are not sure what's happening and they might not be aware about that issues. And conversion dysphonia could be they don't have sufficient adduction for phonation, or they could have hyperadduction, but their voice can be breathy and also at a high pitch typically. So in my practice, I always bear in mind there could be. So that's where the case history and also reframing what patient says actually would help. some patient with I work with some patient who actually very extreme, like when you say cough, they can cough perfectly, but when you say something, they will just completely aphonic. But if you change to do it like cough, for example, if I say ah, it will be aphonic, but if I say cough ah, the ah will come out. So that is a very extreme convention dysphonia. So sometimes I would avoid saying the word say or talk or imitate my speech, everything, but I would just use lots of cough until the point when they actually would realize that, hey, that is my voice. And because it reflects to the earlier presentation of Prof Sani about the teenager, what I did actually with that teenager was she actually went through the process of doing the two voice, and because she is actually have a strong reaction, negative experience being strangulated, so she actually slowly applying that her voice at home, and she has to reorganize cognitively about every environment, because everything happening at home is actually associated with the guy that actually strangulated her. But at the end, that's where she decided that she has to use that voice, the trained voice at school, to protect herself and also her friends. But at home, she will use her normal voice. So I guess that's what actually I would do in the therapy, to actually help them to differentiate the two experience so that they can apply it consciously. When they feel that they're ready, and they can go. And at the same time, I introduce them with, make them aware about the difference in two voice, the contrast and the targeted voice. So if any time they actually turn back to their normal voice, they know how to come back to the targeted voice. Yeah, so that's what I would do.
So what I gather here, all these are actually psychological in origin. But what Madam Sharina pointed out is, in conversion dysphonia, patient do not aware that she or he has dysphonia.
Yeah.
Like primary, is that right? Yeah. They're not aware that, but people telling, hey, what's wrong with your voice? But they're not aware that their voice is hoarse. And like in this case, she forthcoming, saying that there's something wrong with my voice and please help me, something like that. Yeah. So yeah, this one I showed Morrison classification. David has mentioned about Morrison as well, and I think Sharina also mentioned that in psychogenic and conversion dysphonia, rather than hyperadduction of the false vocal fold, like David mentioned, is it type 2, David? The hyperadduction of the false vocal fold, like we saw in this patient. In conversion and psychogenic dysphonia, there is a gap. There's a phonatory gap. Despite normal mobility, there's phonatory gap when the patient is phonating. So that probably another clue how to differentiate either we are dealing with primary muscle tension dysphonia or is it psychogenic or conversion dysphonia. So Puan Sharina had mentioned about, talking to the patient, and then probably find out what is the stress and everything. So this particular patient, I refer for voice therapy to speech language pathology. And during the same sitting, when I saw the patient, I did some laryngeal manual therapy. Taught the patient on straw exercises. You may want to check that on the YouTube, on the speech language pathology papers on straw exercise. And Sharina also mentioned about cough and phonates. I tell the patient to cough and ha, cough and ha. And then they realize that, oh, actually I have voice by properly producing the voice and vocal hygiene. I'm going to show you this video, and in the same clinic setting, I taught her how to do laryngeal manual therapy. Tak mau nak atas. Kuat turun. Saya. Lagi. Saya. Yes. Lagi turun. Lagi. Bring it down. Cakap saya. Saya. Yes. Nama saya Jessie. Nama saya Jessie. Yes. So the idea of laryngeal manual therapy, I'm not the expert in this, but I've seen people doing laryngeal manual therapy. The concept is you want to bring down the larynx,
that is the problem in muscle tension dysphonia when the larynx is so high up and the suprahyoid and infrahyoid muscle is so tense up. So you want to relax the muscle and bring down the larynx. And by the time the patient saw the speech therapist, she got her voice already. Okay, this is her voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan
the voice
nenek
is
pergi.
Normal, and the parameters when you compare the first visit when we saw her, the second visit, the voice handicap index improved. The maximum phonation time is about the same because actually we're not dealing with phonatory gap, and the acoustic analysis has all normalized. And this is the laryngostroboscopic findings of this patient on 2 weeks of that. Right. So before I share another case, I would like to give this floor back to Prof Mawada if there are any input from other panelists.
I think we would like to welcome Puan Sharina to give us a short talk on perhaps some of the strategies that she would usually adapt in speech therapy in patients with dysphonia.
Okay.
Okay.
Puan Sharina.
Hang on, let me share my slide first. Okay, thank you, Prof Mawada. I think first of all, we'd like to just get everyone to think about our voice production. We actually have the privilege to change our voice according to what we want by changing our vocal fold mass. We can have a fold or thin fold. You can shorten it or prolong it to change the frequency. And to be loud, we just need to make sure that we shorten the length of vocal tract, including to take the cricoid or the thyroid and cricoid to be loud, like like to give command in a big group. So we can do it flexibly if we know how to do it safely, because if we don't do it safe, like even to shout but in inappropriate way, then we can end up by having a vocal cord nodule. And from a psychological perspective, voice is really our self-image and it can actually reflect emotions. For example, like in some culture, actually they would expect that a woman should have some kind of falsetto in voice. So if falsetto, to achieve a falsetto voice, we need to have a gap at the posterior. We need to establish a posterior gap. So, and by that way, you can use a falsetto voice, just like how I'm doing now. But if the person is actually a teacher, it's not actually functional. So we can choose to use falsetto voice in our day-to-day talk, but to serve a purpose at work, then we need to have a functional voice. So for voice therapy, we really have to think about what is the right voice and which one is actually a functional voice, because sometimes some patients, they do come with the right voice, but it doesn't achieve the needs in the job or in anything that he really wanted to do. So voice therapy is behavioral therapy, and I said to change behavior, it has to do it with a great intensity. It's not only just the frequency of the therapy, but also the practice at home. And that's a challenge actually, to present the technique to the patient so that they can follow step by step. It's not just about imitate me or try to do this, because it may end up doing it incorrectly. And of course, another challenge I would say is actually to find the correct diagnosis, because what we see from the scope with the ENT, sometimes it doesn't really tell us the exact story, especially for those patients who have psychological underlying. and the psychological underlying could contribute to the voice, or the psychological underlying is actually result of the voice disorder. And I would check about how patients should perceive the voice, and also perceive about what's happening. I had an experience where the patient has a strong thought and strong opinion that her vocal fold is actually damaged and nothing could be fixed. And even if he showed, and even I processed and I actually showed her that this is a voice, this is a vocal fold, it's actually functioning, but the patient just said no, it's already damaged, and I can't. And because of that strong perception, I can't move the patient to another stage. And whether that patient actually aware what's happening. So, and to build up awareness, that's the reason why in my approach, I actually teach them how to actually to produce that hoarseness in voice. But they produce it with voluntarily. They know what to do and how to achieve the hoarseness in voice and how to get back to the clear voice. And also look at their own therapy goal, because sometimes their goals and the therapist goal could be mismatched. And as I mentioned, the frequency of therapy, I think one of the great lesson that we could learn from the pandemic is actually to incorporate the teletherapy, telerehab. But of course, that will be some administrative things that we need to look into in terms of the organization and etc. So, and I mentioned just now, it's about habit change and habit formation. So that's where patients actually, when they first start coming to the voice therapy, they are unconscious, they don't know that they are unskilled. So we make them to be consciously understand what's happening, and also train them to actually do the targeted voice. So I get them to actually to produce the disordered voice and also the targeted voice togetherly, concurrently, right? And by doing that, that's where patient actually can move to become unconsciously skilled. And along this way, that's where we would actually have some conversation with the patient. What are the stressor? What the condition that may trigger the voice problem? So the aim is actually so patient would have control in the voice, and also control in the situation. So we try to actually prevent relapse. And I find it a little bit challenge if there's strong psychological things, because some patients, they do need help from the psychiatrist or counselor, but the challenge to actually dealing with the perception. I had experience where a teacher actually came, and she actually sounded very loud. She always talked in loud. And when we go deeper, is actually she had some anger, which she actually hold behind strongly, and that's the reason why she couldn't progress with voice therapy. Because we talk about the psychiatrist and mental health help, but she actually went with a little bit hesitation. But I think after 2 or 3 sessions, then she find it useful, and that helps us also with her voice. So just a little bit comment about the pubophonic. So the idea is actually to get patient to lowering down the larynx. So we could actually achieve by using cough, or even laryngeal manipulation. I actually use a lot of voice craft approach in my cases, in any cases actually. So by getting them to lowering down and establishing the targeted voice, contrast with the old voice, and to try to maintain the targeted voice. Maintenance could be challenged and could be directly, it could be easily achieved through one session, but in some patients actually they find it difficult, especially with the acceptance of people surrounding, when they have to change their self-image and also their confidence. Because sometimes some people, if they use the male voice, they get some kind of look from other people, because people are so get used with their high-pitched voice. So some patients actually they start at the maintenance rather than establishing or the previous phase of voice therapy. And I think we have comments about this teenager before, and I said this teenager actually he really wants to use his male voice because he actually inspired to be an ENT surgeon one day, and he know to become a prominent ENT surgeon, he has to use the right voice. Okay, so I'm sure you that he will use the male voice. It's just that he need time and some support to establish the new voice, the male voice. Okay, yeah. So for muscle tension dysphonia is also again what we call releasing the constriction, means that to get the false cords move away during phonation. And I actually use voice craft as well to do that. Some people also, like Prof Marina said, use laryngeal massage. Sometimes for conversion, cough may help. So and also again establishing the targeted voice, like the patient also know when to use the straighten voice and when to use the release voice, and actually they know what to actually to hang on which muscle to work, and also the maintaining the targeted voice. And if I relate that with what actually Prof Marina mentioned about the second case, this is not my case, but I wonder what actually the factor that induced, because there's actually one study in a journal when I read some patient with unidentified with psychological component could have relapsed in a voice disorder if they don't know what is actually the stressor. So I suppose that's when I actually do voice therapy, that's a part of work that I would do. It's just not about voice, but it's actually to help them to think about the stressor, what factors actually would affect the voice, how would they undo it, and how would they actually move on. So that's the thing for these two populations. Sometimes in some people with a little bit strong psychological, then I may incorporate breathing just to get them to have a sense that they have some control about using the breathing technique. Yeah. So I suppose it's about having control in voice production as part of voice therapy.
Thank you, Puan Sharina, for the points. Maybe we have some time. Puan Sharina, there was a question in the Q&A box regarding some of the strategies that you may employ in voice therapies in patients with a vocal nodule. What are some of your strategies?
I must say I use a lot of voice craft technique. Some people use easy onsite. I find it a little bit hard because sometimes patient will end up using they actually tend to be a little bit hoarse and they tend to constrict their voice a bit more. And I must say the reason why I like voice craft and I use a lot because it teach patient how to do it in sequence and how to differentiate. So I'm a strong voice craft advocator. I'm user. Everything's about voice craft and including my own voice. So I use a lot of voice craft. Yeah. There are things I might do just to get patient to have some sense that he is actually able to control and have a control about the voice. But that is actually just it's not targeted to for the voice nodule, but it's actually targeted to get patient to have some sense of control in terms of voice production.
Okay, and there was another question regarding speak during inhalation. Does it help in patients with constrictions in muscle tension dysphonia?
I never applied it. I'm not sure. It may, but I don't have experience of using inhalation.
Thank you, Puan Sharina. So I think I will pass the microphone to Professor Marina because we are behind time. So we will quickly conclude with the next case.
Thank you, Prof Mawada. I'm going to share another case. Can you hear my voice? I'm using my AirPods now.
Yes.
Okay, thank you. So this is a 32-year-old male, previously healthy, but complained of hoarseness since 12-year-old. So like when she was young, he has already have hoarseness, and he had history of vocal cord surgery done elsewhere 10 years ago. Was told that there's no malignancy, But since the operation, the hoarseness persists. There's no improvement. He had no swallowing or breathing issues, and no history of TB contacts. Denied LPR symptoms. He has high vocal demand occupation. He works as a priest, and there was no family history of malignancy. Otherwise, other history is nil or significant, and he is also a non-smoker, a non-alcohol consumer. This is his voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan Emma tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan Emma. Setiap minggu saya dan nenek pergi ke rumah ayah. Jika kami tidak ke bandar, ayah, Emma, abang dan adik datang menjarahi kami di kampung.
Okay, so that is his voice. Probably I play the video stroboscopy, the laryngology, the scope findings first, then I ask opinion from the panelists because we run out of the time. So this is the evaluation. Of course, the GRBAS is subjective in nature, like we discussed with Dr. Lau just now. Like he thinks that there's strain, okay, and then I agree with that. So for this patient, I think he has overall dysphonia of grade 3, and the main component is roughness, and there's some breathiness as well. His voice handicap index is high, 33/40. The reflux symptom index is negative, is not significant, and the maximum phonation time is slightly reduced for male. And however, for the acoustic analysis, whenever he say he can produce quite a stable voice. Therefore, the acoustic parameters is quite normal, despite perceptually we can hear that the voice is abnormal. And this is the video laryngostroboscopic findings together with eye scan. So the eye scan 3. Let's close up view. You can bring the endoscope as near as possible to the vocal cord, but you must be good in your technique. That is on phonation, on white light. And now I'm on stroboscopy. And you can combine the stroboscopy with eye scan. That would enhance if there's any inferior surface lesion that can bring up during the phonation. Okay, with that, I would like to ask from panelists, probably from Prof Zul, what do you think of the patient's voice? And based on the assessment, the laryngoscopic assessment, the voice assessment, what do you think the differential diagnosis with regards to the voice problem of this patient?
Yeah, thank you, Prof Marina. I think, it seems like significant hoarseness over this patient, but from the endoscopic laryngoscope just now it showed to us, the anterior part of the right vocal fold, it seems there is a fungating mass surrounding that area, and then this mass, the whitish discoloration. So I suppose one of the differentials that I can say can be atypical infection like fungus or tuberculosis. One of them can be, but we cannot rule out tumor, one of them as well. So yeah, and then other than that, I cannot. We need to assess further, and biopsy is the best to find out what's the exact problem on him.
Okay.
Thank you.
Thank you, Prof Zul. Probably I can invite David if you want to give some opinion on this.
Certainly, I agree with Prof Zul. I think to me that should be a carcinoma until proven otherwise. It's a leukoplakic lesion of the midcord.
Okay, thank you so much. So when I got this referral, that is in the mind of the ENT surgeon who referred the case to me. However, I would like to point out that when we do this examination, when white light, it looks like a pre-malignant collision with probably hyperkeratosis. But then we can notice that he has some edema of the vocal fold as well. It's like probably Rinke's edema underlying it. But something that is marked when we change to stroboscopic view is the patient could close the vocal fold, could close the phonatory gap, and you can see vibration, and you can see that the mass is kind of flopping. You can appreciate that. Yeah, it is flopping superiorly and inferiorly. That make me think that maybe we are dealing with telangiectatic kind of vocal polyp with some hyperkeratosis overlying it, possible. So, and so that's addition to what Prof Zul and David had mentioned. So at this time, these are the differential diagnoses in my mind, and I agree. We have to think about pre-malignant lesion. We have to think about glottic carcinoma, like David had mentioned, and we also have to think about TB larynx. Therefore, we did some TB workup as well. But deep in my thought, when looking at stroboscopy, I think maybe we are just dealing with vocal cord polyp. So I want to show you okay, before I show you what we found intraoperatively, this is something like pertinent within this webinar with regards to the instrument that we use when we want to perform endolaryngeal microsurgery. David had pointed out a lot of salient points in his lecture, and he mentioned about 1 millimeter instrument. Okay, so I'm going to show you this is a comparison between a big instrument and micro instrument that you should use in endolaryngeal microsurgery. The size, for example, this is a Bucheyer forceps. The size is just 1 millimeter or just more, a little bit more than 1 millimeter, whereas the other one is about 3 millimeter. So you should use the small one if you are doing any vocal polyp surgery, vocal nodule surgery, any precision surgery. So size matters, yeah, when we choose instrument in performing the surgery. So this is the surgery, and then I would ask the panelists to comment and probably how we can improve, or maybe tips, how can we do this surgery better? We use ball probe because it's hard to hold the mesh with Bucheyer forceps. This is too big. And we can see the stalk. And now we're doing hydrodissection. And I hope you can appreciate that during the hydrodissection, everything swell up, the superficial lamina propria, except at the stalk. It indicates that maybe that area there's already scar because it doesn't elevate with hydrodissection. And now we are using sickle knife, pushing the mass with a laryngeal probe. Sickle knife, high magnification, like David had mentioned. High magnification, so you can see the layer of the vocal cord. Now the sickle knife is just cutting the epithelium, the mucosa. And use laryngeal elevator to elevate, avoiding injuring the vocal ligament. And there's a lot of bleeding because there's a lot of dilated vessels. And it's important to stop the bleeding using adrenaline, patty, or ribbon gauze. Don't just cut, without knowing where you go. And now we use Upton scissors after we have determined where is the stalk and we have elevated it from the vocal ligament. There's a lot of bleeding. So this is another tip, you can use patty or a ribbon gauze put on that and suck on the ribbon gauze and try to identify where the bleeding come from and try to stop the bleeding by compression. You can see vocal ligament underneath that. Stop the bleeding. Then hold the flap that you have raised and use Upton scissors to cut the rest. And after that, this is incidental finding, which we didn't see it on stroboscope. This patient also have mucosal breach on the opposite vocal fold. This is complete. This is mucosal breach. And just below that, he has another sulcus. And I saw a paper describing this as incomplete mucosal breach. So this patient on the opposite vocal fold, he has two breach, one complete, another one incomplete. So I was thinking that maybe the polyp that arise from the opposite vocal fold maybe started off with mucosal breach and patient abused the voice and then developed polyp on the breach. And then there's bleeding. I learned this from David. David said use monopolar only 1 watt. I stopped the bleeding using monopolar 1 watt and the bleeding stopped. Just 1 watt, just touch and go. And that is the end of surgery. Okay, so I would like to invite from the panelists, some opinion on probably ways to do this surgery better, and also what would you do to the mucosal breach? Would you excise it intraoperatively, the same sitting, or you would just leave it alone? Maybe Prof Sani or Prof Zul or David or Prof Masani. Yeah.
Of course, you advantage of hindsight. You must look at the stroboscope. If it's possible to look at the stroboscope again, to look at the mucosal wave on the contralateral side. Now, if the mucosal waves on the contralateral side is normal, I would just leave that lesion alone. Leave the lesion alone for the time being. Yep. Of course, you can't remember. If you can't remember, then it's fine. I would not touch that primarily, because but if you accidentally cut higher, then you cause two opposing fresh lesions, and it's always safer to come back again if you need to be. Again, you are guided again by the stroboscopy post-operation. So no, I would not do anything to that side at this sitting. I would review the patient later and look carefully at the stroboscopic picture post-operatively. If the stroboscopic picture is absolutely normal, we should leave it alone. I'm sure that this operation will give a tremendous improvement of the voice, and therefore the patient will much appreciate it. I don't think he wants another surgery, but everything again depends on what happens after this operation. I would like to tell this the audience, in such cases when you do this kind of fine surgery, do not forget PPI post-operatively, because not because of anything, because when you do this surgery, if you get reflux, even one acid reflux in a day, a post-operation, it will affect the results. So I think we should give the patient PPI after the operation. It's just a reminder to. I'm sure we all do that. Just a reminder to the participants, if you do this kind of surgery, you're exposing this raw area in the vocal cords. You must be very careful about acid reflux.
Yeah.
Thank you.
Yeah, I agree with Prof Sani. We do give PPI prophylactically, although there's no strong evidence, there's no comparison whether we give or don't give, but we always give. I don't know, to treat the patient or to treat the surgeon, but it's worth it. We give the PPI. So if no, yeah,
I'd like to say something. Very nice surgery. Love the fact that you did not disturb the vibratory surface of the vocal fold, the medial surface. I usually, if it's not, it doesn't look like a malignant lesion, I usually hydrodissect with a mixture of steroids and adrenaline, and it helps with the bleeding.
Okay.
Even Prof Sani, even for my posterior cordectomies. Because I don't want that place where I do the cordectomy to heal fast, so the DEXA will stop the healing.
Okay, so you mix steroid, you mix dexamethasone, it's steroid, with adrenaline.
Yes.
Before
with
you
the
start
bleeding a lot.
Yeah, you do hydrodissection with that.
Yes.
Okay, thank you.
Okay, I would like to add that you know, even with all the fancy stroboscopes and scans and so on, at the end of the day, examination and anesthesia is the most important thing, you know. And although the audience will see, oh, the lesion is clearly seen and so on, but I think the audience must appreciate that exposure is everything. You know, it's not like, oh, you know, it's easy to see. It's not. What is important is the placement of the laryngoscope, the choice of the laryngoscope, the choice of the endotracheal tube, and then and all the scopes that we have, the 70-degree scope, the 30-degree scope, for example, the 0-degree scope. It's all very important. The examination and anesthesia is part of the investigation at the end of the day. And then the final thing that you need to do for this patient really depends on what you find under anesthesia. So I think that cannot be overemphasized. And you know how you expose the lesion. I know of, if your hospital does not have the as unfortunate and doesn't have the instruments, you find that this surgery is very, very difficult. In fact, maybe impossible to expose the lesion, and then surgery will be impossible. Please do not try to do surgery when the exposure is not adequate or optimum. Thank you.
Okay, thank you, Prof Sani. So before I move to the next slide, just adding about the mucosa bridge, there are controversies on how we treat mucosa bridge. But many authors propose that if the mucosa bridge is thick, rather don't cut it, because you will the vocal cord will lose some volume, and that would affect the mucosal wave. But if the mucosa bridge is thin, you may cut it, excise the mucosa bridge. So there's some controversy, how you should treat the mucosa bridge, because cutting the mucosa bridge also can cause scar later on. So and we have done this, and this is the histopathological examination. It's vocal cord polyp. There's a lot of dilated vessels. So some authors call this as telangiectatic polyp because there are that many vessels within it. This is the voice assessment of the patient. The GRBAS is not really changed because we still have mucosal bridge on the opposite side, but patient very happy with the voice. From 33, the voice handicap index reduced to 8, which is within normal limits. The maximum phonation time increased significantly, and the fundamental frequency unchanged, still within normal limit. So this is the patient voice.
Semasa saya kecil, saya tinggal di kampung bersama nenek. Ayah dan emak tinggal di bandar. Abang dan adik saya tinggal di bandar bersama ayah dan emak. Setiap minggu saya dan nenek pergi ke rumah ayah.
So I think maybe you agree with me that the voice sounds cleaner and better voice projection. And yeah, as Prof Sani said, he refused to come for follow-up, just one follow-up. And after that, he refused to come because he said he's okay, he can do his job, and he lives South Malaysia, Semenanjung Peninsula Malaysia. So it's, with this COVID pandemic, he refused to come. This is a visit 1 month after the surgery. I would say that at this time, the stroboscope is not optimum because we have issues with the microphone. So bear with me, the stroboscope is not actually what that is. But what you can see is the whitish thing is saliva. There's web over there. Web is present even before we did the surgery. And then, so we use eye scan. So that is the stroboscope. We can appreciate that there's vibrating segment
over the side that we have done the surgery. But this stroboscope is not optimum because we have problem with the microphone at that time. Okay, so it is vibrating, but you know the mucosal wave looks asymmetrical. All right, thank you so much.
He has severe reflux, no? You can
He
see
has, yeah.
Yeah.
So yeah, he is on PPI as well.
Thank you, Prof. Marina, for the interesting case just now. I think we learned a lot from the case. So I think we've got 10 more minutes to go and we have less time for the next case, but don't worry, I'll be sharing the links to the vocal cyst surgery that we're supposed to share for the next case in the chat box soon. So before I end, I would like to share the poll questions results. So I've got it here. So looking at our participants, so benign vocal fold lesions that they would treat primarily with surgery. Mainly they would treat vocal fold polyps primarily with surgery. And then more participants are less confident with vocal fold cysts. Yeah, they tend to rupture. I think that's true in most of the cases. And we've got some participants who would like to treat nodules and granuloma, most with speech and voice therapy first. So we have Dr. Fauzia Fardiza from Jakarta. Perhaps Dr. Fauzia, how is your practice there in Indonesia? Which benign vocal fold lesions would you treat primarily with surgery?
Thank you, Professor Mawada. Can you hear my voice?
Yes, loud and clear.
Usually for the nodules, we do the speech therapy first. And then also sometimes people with nodules, for my experience, is they have a fragile vocal cord. So like if we should see the underlying disease also, and we have to correct them, like blocked nose. So if they speak, if they not clearly with the voice, so they will push the vocal cord more, like abusing the vocal cord. So for the nodules, we did the treatment first, the speech therapy first, and for the cysts, this is tricky. Sometimes we did this therapy, but it always failed, so we have to do the surgery. And
Yeah.
also the granuloma.
Yeah, I tend to agree with you. So the vocal fold cysts are usually more recalcitrant to speech therapy, but more challenging to perform these surgeries, yes? Right. So with that, I think we have reached the end of today's show. Before we end the webinar, I would like to thank the excellent speakers and panelists who have contributed towards this webinar in today's discussion. And if we have a short moment, maybe we can have a small group photo. I would like to ask all the participants to switch on their videos. And if I can have Dr. Isaac to take a gallery view photo of all of us. Overwhelming responses, and we've got a lot of questions being answered, nearly 50 questions there. Dr.
So
Isaac.
from Mawada, while waiting for Dr. Isaac, maybe we can tell the audience that we will provide the details of the webinar, the next session, about around 2 weeks before the session.
Yes. The links to the Zoom link will be provided via your email, and we will give them 2 weeks prior and 1 day before. So Dr. Isaac, are we ready to take a group photo?
Oh, okay, Prof. Hold on.
All right.
Okay, Prof, can you stop share screen?
All right.
I smile for quite some time already.
As usual.
Okay.
Photo, everyone.
1, 2, 3.
Thank you. I think we've got many pages to go, so please bear with us.
One, two, three. 1, 2, 3. 1, 2, 3. Okay, Prof, I think that's more or less.
Thank you, Dr. Isaac. So,
From Awa,
yep.
just to say some acknowledgement
Yes.
to the registrars who are helping me with the preparation of the case discussion slide and taking video of the operation. Dr. Tan Sweet Ting, Dr. Eliana, Dr. Irfan, and many other registrars who have been helping a lot. Thank you.
So thank you, everyone. And do tune in to our next event, which will take place on the 17th of March, 2021. And we'll be doing neurolaryngology topics. And the moderator for the next session will be Dr. Nick Fariza. I'm sharing with you the QR codes for our feedback form, as well as the QR code for the MMA event CPD points. So last but not least, I had a terrific time moderating this webinar, and we had a lot of great interaction, and we were able to answer all the questions posed despite our time limit. Till we meet again in the next webinar, stay safe, everyone, and thank you.
Bye. Thank you.
Thank you to all
Bye.
faculty members. See you next time.
Thank you, Prof Marina, Prof Sani. Hi, Mas Sani.